lecture corresponds to your lecture, The Rhythmical Excitation of the Heart in the Normal ECG. This is the first part of the lecture that corresponds to the cardiac conduction system. This is the specialized system within the heart that allows us to spontaneously generate action potentials and then conduct these action potentials throughout the heart, allows the heart to work in a very coordinated fashion. The second part of the lecture corresponds to the electrocardiogram, what we can visually see when we look at the electrical activity associated with the heart. So this first part, we're only going to just deal with the specialized system, the cardiac conduction system. When you look at the heart itself, the electrical cells, which are the ones that we're going to be talking about today, these are the cells that initiate the electrical activity. They will generate the action potentials. Then some of these electrical cells will then conduct the electrical impulses from where we initiate the electrical activity throughout the atria and then throughout the ventricles and initiate the contraction of the myocardium, the muscles, the cardiac muscle cells. Now the mechanical cells are the muscle cells. They will contract in response to the stimuli from the electrical cells. So the action potentials that these electrical cells are generating and conducting through the heart, they will stimulate the muscle to contract. Now those muscle cells comprise the majority of your heart, the bulk of your heart. Those muscle cells are responsible for when they contract, they generate that tension. And the tension buildup generates the pressures that allow us to move blood from the heart either up toward the lungs or to the rest of your body. The cardiac cells, it's important to realize a couple characteristics of these cells that kind of is important when we talk about the fact that why we have such a specialized system within the heart. One, they exhibit what we call automaticity. It's automatic. The idea is this has to do with the fact that they can create or generate their own action potentials. So the definition, which you will write down in your notes, is something that exhibits automaticity has the ability to generate their own action potentials without external stimulation. Cardiac muscle cells are not unique in this, but they are definitely exhibit this. Skeletal muscle does not. Skeletal muscle needs the nervous system to be able to tell it to contract. Cardiac muscle does not. They do not need external stimulation, which would be example, the nervous system. When we talk about smooth muscle in physiology too, you're going to learn that smooth muscle, when we look at certain types of smooth muscle, they have an ability to generate their own action potentials without external stimulation, which is kind of interesting. But one thing to realize, this is a big difference between cardiac muscle and skeletal muscle, is they have automaticity. They also exhibit rhythmicity. Rhythmicity is an ability to generate those action potentials in a regular, repetitive manner. So this part down here is the rhythmicity, being a regular, repetitive fashion or manner. So they have some rhythm. Why is it so important that they have rhythmicity? Think about the coordination that's needed to be able to generate the right pressures to get blood from, say, the atria then to the ventricles, and then the ventricles out to the rest of the body. You want everything to be very coordinated. So here, I want to kind of review with you something I know you probably learned from Cells and Tissues, and it has been mentioned earlier this trimester, is that the heart, the structure, is specially designed to allow the heart to kind of work as a unit or a syncytium. So syncytium, kind of these cells are going to kind of work together, not as individual cells. The atria work together as a unit. The ventricles work together as a unit. And the way the cells are designed is that they have these structures right here. You see them here, here, here. In this picture, this drawing, they're drawn right here. These cells, do you remember what they're called again? Or not cells, structures, should say. They're intercalated discs. So intercalated discs are unique to cardiac muscle. They're composed of gap junctions, which we had mentioned that you see gap junctions in unitary smooth muscle, allows smooth muscle to work as a unit. But these have gap junctions and desmosomes, or another term for it, I believe, is macula adherens. So you can see them right in here. Allows that when the muscle contracts, that they don't break apart from each other. But what's important for you to remember now is the gap junctions. These gap junctions allow the electrical activity to move from cell to cell fairly quickly and allows the heart to work as a unit. Now I have a little, it's a very short animation which will show you the idea that when you look at contractions within the heart, you begin with the atria and then the ventricles. And what you're going to see is the electrical activity that begins up in the pacemaker of the heart. It's transmitted through the atria. Starting from up here, we're going to start from the pacemaker of the heart, which is considered to be the normal pacemaker of the heart, the SA node, or the sinoatrial node, or sometimes you'll hear it called the sinus node. We're going to start here, and I'll move our way kind of shortly, or slowly, through the various components of the cardiac conduction system, and kind of go over the order in which the electrical impulses are moved throughout the heart. So we're going to start right up here with the sinus node, and then we'll move our way down. So we're going to start with the sinus node, or the sinoatrial node. They have these special cells called P cells, and the P cells are kind of short for pacemaker cells. These cells are located, if you look in the previous picture, they are located up in the right atrium and actually the superior lateral wall of the right atria. So it's a little kind of specialized muscle, and the thing is, I call it muscle, but it has kind of changed over the course of evolution, that it originally was muscle, but it has lost most of its myofibrils, so it has very few myofibrils. So it does not have very many contractile elements or filaments. So these cells do not contract. These cells are responsible for generating the action potentials, the electrical activity in the heart. So these guys are going to get the ball rolling. Now these cells here, these P cells, are directly connected to atrial muscle cells. So once these cells start the ball rolling, the electrical activity will move out directly into the atrial muscle, but they also have these cells, so you have these transitional cells, that start moving the electrical impulse also down towards the ventricles. But we're going to tell you exactly where they're going to go. Now what's important to realize, though, is why these cells are considered the pacemaker. These cells set the basic pattern or rate and rhythm of the heart, because these cells spontaneously depolarize. They do not need nervous system input. If you look at an action potential from the SA nodal cells, here's a picture of the action potentials that are in the nodal cells. They exhibit what we call the slow response action potentials. Over here on the left is an example of a fast action potential or fast response action potential that, for example, you'd see in the ventricular muscle. And this picture is an example of what you would see in ventricular muscle. You have seen these pictures before, okay, so it's not the first time that you've seen it, but I want to reiterate some things that Dr. Kayes-Wandover has discussed with you. One thing, when you look at ventricular muscle, the upstroke of the action potential, which you see here, phase 0, that is the depolarization, and that's because of sodium influx into the cell. You'll notice that the resting membrane potential in the ventricular muscle is minus 90 millivolts. when there's the influx of sodium, the cell will depolarize and you see it coming up. Well, in these nodal cells, the action potential is about minus 60 or minus 55 millivolts. So it's not as negative as you see in the muscle cells. And there's going to be a reason why. Okay, there is a reason why. And this is it. These cells are leakier to sodium. So when the cells, because the cells are leakier to sodium, those positive charges neutralize that, the negative, normally that negative charge that you see here, so it's not quite as negative you see over here. They're also, they just kind of come in, the sodium's coming in, the sodium's coming in. They're much closer to threshold. When the cells reach their threshold potential, which is minus 40 millivolts, you will get the action potential that's generated. And the phase 0 that you see in the slow response cells is not because of sodium flux. It's because of mainly calcium. It's actually what we call slow sodium calcium channels. The reason why, as at this membrane potential, the sodium channels are already turned off. They're already inactivated, so they do not play a role in the action potential that you see in the slow response type cells. This is because of predominantly calcium inflow into the cell. So there's a big difference between the two for phase 0. You'll also notice there is no plateau phase that as you see in the ventricular muscle here. They do have a phase, and they don't have a phase 1 either. The phase 3 is still because of potassium efflux. Okay, so that's the same. So biggest difference is, or here's another, I'll add another one. Biggest difference between the two is the membrane potentials are different. And the reason why it's less negative in the slow response is because these cells are leakier to sodium. The other big difference here is the phase 0 is in the muscle cells, it's due to sodium influx. In the nodal cells, it's because of calcium influx. Those sodium channels are already turned off and inactivated. You'll notice too, over here, that there is a true resting membrane potential. It kind of stays minus 90 until you depolarize it, and it goes up pretty quick. Over here in the slow response cells, it slowly, never really has a true resting membrane potential. It kind of slowly creeps up. See, it kind of creeps up here, and even when we've repolarized it, it just starts coming back up again. So it does not have a true resting membrane potential. A lot of textbooks, instead of calling it a resting membrane potential, they'll call it a pacemaker potential rather than a resting membrane potential because it never rests at a constant value. So here's kind of a big difference between the two. So the SA nodal cells have, and this is kind of showing you same thing again. You also see they call it prepotential in some textbooks. So they exhibit automaticity because they are leakier to sodium. Sodium just coming in. Once you reach that threshold, it's going to discharge, and you're going to generate the action potential. Now the action potential is a little bit slower than you saw with ventricular muscle, and it repolarizes a little bit slower, but doesn't matter. It's still going to spontaneously depolarizing without external stimuli. So this here refers to those ion channels that are kind of unique. What's responsible again for this part, this phase 0, is because of what ion channels? Predominantly it's calcium influx. So the SA node spontaneously depolarizes faster than any other cell within the heart. So it is the pacemaker. It's going to set the pace of the heart. So in a race, if you've got the leader in the race, this would be the leader. This one, or the pace car, if you want to talk about NASCAR or something like that. This is the pace car. Everybody's set to this pace. Now the SA node spontaneously depolarizes at a rate between 60 and 100 beats per minute, or corresponding to a heart rate of 60 and 100 beats per minute. So our set rhythm or rate for our heart is anywhere from 60 to 100. That's considered normal. Anything from 60 to 100 beats per minute is considered normal because that's the spontaneous depolarization rate of the SA node. Now when this fires, which you see up here, this needs to, the action potentials need to be transmitted throughout the atrial muscle and eventually down to the ventricles. So we need some specialized cells to help us to get it down to the ventricles and over to the atria fairly quickly. So we start here in the SA node. Remember I had mentioned that those cells are directly connected to atrial muscle, so it will start moving through here, the muscle in the right atria. But you also need to get that electrical activity over to the left atria. So you have these this interatrial band. And so the interatrial band means between atria. So it's going to transmit the electrical activity over here fairly quickly. And you also have what we call internodal pathways. Think about it. Why do they call them internodal pathways? If you look at the little line, we're seeing this line going from the SA node down to this structure here, which is the AV node. So it's between nodes. So this electrical activity is going to be spread out this way, out here, and also simultaneously down to the AV node. Now, the atrial muscle itself conducts the impulse relatively slowly, about 0.3 meters per second. Well, that really is, to me, not that slow, but it is slow compared to any cells that are part of the conduction system. The internodal pathways and this interatrial band will speed up the conduction up to about 1 meter per second. So it allows us to get this impulse down towards the ventricles, it's not there yet, fairly quickly. So we're sending it out over to the other side, sending out throughout the muscle here in the right atria, and the impulse down towards the ventricles. So eventually, you've got the electrical impulse generating those action potentials. The atrial muscle will eventually contract and hopefully contract as a unit together, allowing us to completely fill up the ventricles. Well, the ventricles need to eventually contract so we can get the blood from the ventricles out. But we want these guys to contract and allow the ventricles to fill. I do not want the ventricles to contract at the same time as the atria. That's why we have this in here. So here's the significance. The electrical impulse makes its way down to the AV node. Well, the AV node has the cells in the AV node are a little bit different. You're going to have a significant slowing of conduction of the impulse through the AV node. So here, through this structure right here, the AV node, the impulse is delayed 130 milliseconds, which is 0.13 second. That number is going to come back later, so it's kind of an important number. So you get 130 millisecond slowing or a delay right here. So that allows these guys to contract and completely help top off those ventricles. The fibers in here are small. There are very few gap junctions, so that's the reason why the impulse is significantly delayed compared to any other part of the heart. The transmission of the impulse is 0.02 to 0.05 meters per second. So that's way slower than you saw in the atrial muscle. It's way slower than you saw with the internodal pathways. So why is it necessary to go direct those signals through the AV node? Because I want the significant delay to allow time for the ventricles to fill. But also, I'm sending the impulse to here. Now this picture doesn't show it, but remember the connective tissue that separates the atria from the ventricle and where the valves are attached. That was the annulus fibrosus. It will stop the electrical activity that's coming from this part here, from the atria from going directly to the ventricles. The only normal way you're going to get that electrical impulse to go in the ventricles is going AV node and then through this part here, the AV bundle. The AV bundle is also called the bundle of His. That will penetrate the annulus fibrosus. So the AV bundle is the only normal way you can get the electrical impulse that originated up in the atria down to the ventricles. So in the AV bundle, or that bundle of His, I prefer bundle of His personally, but AV bundle is perfectly fine. In this part of the conduction system is where Purkinje fibers begin to originate. And I know you've heard of that term Purkinje from Cells and Tissues. This physiologist put his name on a lot of stuff. The Purkinje fibers are part of the Purkinje system. They originate up here in the bundle of His, and then they're going to come down, that you see kind of in the blue. These all consist of either bundles of Purkinje fibers or terminal Purkinje fibers. So the Purkinje fibers transmit the impulse really, really quickly. But before I talk about why it goes really quickly, I again want to give you the significance of why you have the annulus fibrosis that separates the atria from the ventricle, and that the bundle of His is the only normal way that we can get that electrical impulse down to the ventricles. So remember, the electrical activity will die off when it hits that annulus fibrosis. It acts as an electrical insulator. You do not want that electrical activity to go directly from the atria to the ventricles, because what's going to happen is up here, the muscle fibers up at the base of the heart would be the first to contract. I do not want my heart to contract from top to bottom, and I'm talking about the ventricles, because blood needs to go from this up that way. So here, we're not going to allow that to happen. The electrical activity is going to go through the bundle of His. Now watch how it goes down. These Purkinje fibers are going to transmit this electrical impulse very, very quickly, up to 4 meters per second. They're very large fibers. What happens is it's going to come down through the bundle of His. It's going to have, you look on this side, this is what's called the right bundle branch, because it's on the right side of the heart. This here is the left bundle branch. They are big bundles of Purkinje fibers. They will carry that electrical impulse down through the septum. So these guys run along the septum, the ventricular septum. They move down towards the apex. Now the left bundle branch actually does have some branches up here, but we're not going to discuss that. At a later time, if you want me to discuss it, you can always ask me. But right now we're just going to discuss just the left bundle branch. So the right bundle branch, its job is to get the electrical impulse to the right ventricle. So it's running down to the septum, towards the apex, and then you'll notice that these terminate into what we call terminal Purkinje fibers. Those Purkinje fibers kind of penetrate maybe just a third of the way into the muscle itself, and those terminal Purkinje fibers are right there next to muscle. So the impulse gets carried down through the ventricle fairly quickly, but also then transmitted to the actual muscle itself. The left bundle branch, which is again a big bundle of Purkinje fibers, runs down the left part of the ventricular septum towards the apex, then comes up this way towards the base, again terminates in these terminal Purkinje fibers. The left bundle branch job is to get that electrical impulse to the left side of the heart. So one good thing about having these Purkinje fibers, and that they move so quickly, to get the impulse to most of the ventricles, it only takes 30 milliseconds. That's amazing when you look at the size of the ventricles compared to the atria. Actually, the ventricles depolarize quicker than the atria, and they're bigger. It's because of these Purkinje fibers. Now, if you look at this picture, what you have in your notes, what here these numbers correspond to is the amount of time that has elapsed from where the impulse was initiated in the SA node, just to kind of give you a frame of reference of how quickly things occur and how much time things have occurred or has taken place. And it'll give you an idea of the order of depolarization and thereby the order of contraction. So let's walk our way through it. You start in the SA node, it fires. That impulse makes its way to the AV node in 30 milliseconds. That's pretty quick. Makes its way in 30 milliseconds. The impulse is also transmitted to the left atrium and also the remaining part of the right atrium. Remember, it's going to go through the interatrial band over here. The SA node is connected to atrial muscle. This here, it's making its way down to the AV node is through the internodal pathway, means between nodes. You notice that the atria has completely depolarized, if you look at this number here, in 90 milliseconds. So in 90 milliseconds, all the atria has completely depolarized. So you see it here in purple. Starts in the SA node, starts to move down. You see it moving here. Okay? Then you see from here to where it makes its way to the bundle branches, it's made its way to the bundle branches 160 milliseconds after the impulse has originated in the SA node. But if you look at the numbers from here to here, how much time has elapsed from it reaching the AV node to getting to the bundle branches? That is 130 milliseconds. Remember I said you're going to hear that number again. So that represents the delay that you see that has occurred through the AV node in the bundle of His. So the AV node, significant majority of that delay is within that AV node. So the 130 millisecond delay at the AV node is extremely important. So we have a little bit of slowing, allows these guys to contract, fill up the ventricles, and that would be during atrial systole. Okay? Then you see the impulse making its way down through the bundle branches. Here's the right, here's the left. They move down towards the apex, up towards the base, and they terminate into those terminal Purkinje fibers. Now you'll notice that the septum depolarizes first. That's going to kind of act as a prop for the remaining part of the ventricles to contract around it. So the septum depolarizes first. It will be the first to contract. And then we will depolarize the apex up to the base. So you see it come down, apex up to the base. So the apex of the heart will be the next to contract, and then it moves up towards the base, because isn't that the direction in which you want the blood to move? From down here up to the opening of the semilunar valves. You'll notice that if you compare the time here to over here, that 0.16 to 0.22, that it takes about if I do the math right, about 0.06 seconds or 16 milliseconds for all of the ventricles to depolarize. That's pretty quick. Again, tell me why the ventricles all the ventricles can depolarize in 60 milliseconds when it's the atria took 90 milliseconds and the atria are smaller. Because what is in the ventricles? It's the Purkinje fibers. They conduct the electrical impulse really quickly. The muscle, the cardiac muscle itself, the ventricular muscle, transmits the electrical activity fairly slowly. So it's about 0.3 to 0.5 meters per second, which is about a sixth of the Purkinje fibers. So that may become important at a later date if there's a problem with conduction through, say, the bundle branches. If I have some sort of blockage here, the only way I'm going to get that electrical impulse transmitted to the heart will be going from the cardiac muscle to cardiac muscle, which is much slower, which we may be able to see by looking at the EKG, and clinically it will be significant. But right now we're just looking at the normal values. So let's review the depolarization pattern of the heart. Starts at the SA node, that's our normal pacemaker. It's transmitted towards the ventricles to the AV node through the internodal pathways, but the AV node is not in the ventricles. The AV node is still in the right atria, kind of around where the coronary sinus would be emptying, kind of near the valve too. The impulse is moved over to the left atria through the interatrial band. The atria depolarize within about 90 milliseconds completely. All of them depolarize within 90 milliseconds. You get a 130 millisecond delay at the AV node. So it's going to go from the AV node through the bundle of His, then down to the bundle branches, the right bundle branch, the left bundle branch, and it moves down towards the apex, then up towards the base, and terminates in those terminal Purkinje fibers. The ventricles will be completely depolarized with about 160 milliseconds. Or not, sorry, 60 milliseconds. Sorry, couldn't do my math. 60 milliseconds. So the order of contraction would be atria, little delay. Then the ventricles contract. Septum contracts first, muscle spirals down at the apex, and then up towards the base, because that's the order. I want the blood to move up this direction. Now, question is, what happens if there's an issue? Maybe SA node couldn't fire. There's something wrong with it. Well, there are other areas within the heart that can assume the position of being a pacemaker. They have automaticity. They normally have automaticity. So we have P cells in the AV node, which connect as pacemaker cells. The Purkinje cells don't have P cells, but the Purkinje cells also can exhibit automaticity. Well, the SA node normally is the pacemaker. So it's a question, well, if these guys can exhibit automaticity, why is it the SA node is considered the pacemaker of the heart? Well, when the SA node discharges, its impulse goes to the AV node and the Purkinje fibers and then discharges those fibers. The SA node will fire again before the AV node or the Purkinje fibers could reach their threshold for to generate their own electrical impulse or their self-excitation. These guys, the SA node depolarizes at a much faster rate compared to the other two. So these guys are stimulated to discharge before they would even be able to discharge on their own. So normally SA node is like the dominant. This sets the basic pace or rhythm of the heart. The AV node has a spontaneous depolarization rate of about 40 to 60 beats per minute. Remember, the SA node is 60 to 100 beats per minute. AV node is from 40 to 60 beats per minute. The Purkinje cells, they have a spontaneous depolarization rate of 20 to 40 beats per minute, and they're not very reliable though. They're not. So why do you need to know this? Well, here's the scenario. If I have some sort of block in conduction from the SA node to the AV node, which is very, very common. If there was a block and I did not have the AV node assume the position of being a pacemaker, the ventricles would fail to contract, you would not be able to pump blood, and you would not last for very long. So SA node fires, bam, but the impulse couldn't make its way to the AV node. There's some sort of problem with conduction. The AV node will spontaneously fire anywhere from 40 to 60 beats per minute, and then that impulse would go down to the ventricles through the normal pathway through those Purkinje fibers, the bundle branches, the terminal Purkinje fibers, and the ventricles would then therefore be able to contract. But what's going to be the big difference? SA node fired, no problem. It just didn't have, it couldn't get down to the AV node for some reason. Maybe there's something wrong with the internodal pathway. Well, atria are going to contract anywhere from 60 to 100 beats per minute. The ventricles are being controlled by the AV node. The ventricles will contract at a slower rate, anywhere from 40 to 60 beats per minute. What we have is what we call an escape rhythm. The AV node has escaped from the dominance of the SA node and has created a new rhythm, a ventricular rhythm. So these ventricles are contracting at a different rate than the atria, and that is, believe it or not, relatively common. The Purkinje cells could also assume the position of being a pacemaker if you've got a problem at the AV node. So the impulse can't get from the AV node down towards the Purkinje system. So the Purkinje fibers, or the Purkinje cells, will assume their automaticity and create or allow those ventricles to contract at a certain rate. But here, it's only anywhere from 20 to 40 beats per minute, and they can't be relied on. They may decide, oh, I'm not going to fire. So if you have something like this, this is really significant. And definitely if you have a ventricular rate of 20 beats per minute, you would not be conscious. I can guarantee it, okay? But we will talk about that when we talk about an abnormal EKG. So this is what we're just doing now, is kind of talk about the normal cardiac conduction system, its significance, and the next part of the lecture is to look at the normal EKG. So we'll look at that next time. So right now you can take a break.